I am a long-term survivor of stage 3C colon cancer. I am a researcher. I was on Judah Folkman's staff for 12 years until his demise in 2008. And I'm a patient advocate. I'm on the board of directors of the Colon Cancer Alliance. It's a pleasure to be here at this conference. I was diagnosed, as I mentioned, with stage 3C colon cancer in November of 1994. This was no symptoms. This is just a routine physical exam. I had turned, I don't know what year it was, 55 or something like that, and triggered a routine physical exam. FOBT was positive twice, and that triggered a colonoscopy. I was awake during the end of the colonoscopy, and I saw this big, ugly tumor on the screen, and I knew exactly what was going on. No anxiety, no waiting for biopsies, pathology report. I knew exactly what was going on. I'm a cancer researcher. I have been studying tumor growth for a number of years, and I came to the conclusion, your audience may or may not agree with this, but I came to the conclusion that the short course intensive chemotherapy that's conventionally used is probably not optimal. And for myself, I just chose a long-term low-dose chemotherapy. This was a variation of a therapy that had been used in late-stage colon cancer before, just using the standard 5-FU drug that's been around for decades. And it was given every night for 6 hours at a reduced dosage of about 30% reduced from what is commonly accepted to be the conventional long-term tolerability limit. And the toxicity profile in these drugs is pretty steep, so just cutting the dosage back by 30% made a world of difference. I had no toxicity. I had a couple mouth blisters. This is over a 2.5-year period. I had some numbness on my fingertips, and my fingernails grew in a little coarsely. Other than that, nothing. I didn't vomit at all. I didn't take an aspirin. Didn't miss a day of work. I'm not sure this is for everyone. I think that the current standard therapy is fine. I just thought that for myself, I wanted something that had a little more science behind it, and that's a personal decision. I would not impose this on anyone. I published a paper, I think about a year ago, describing my reasons why I did not use the conventional therapy and what exactly the therapy was. So it's out there, it's in public, it's on the web, and it's free to download. Just Google my name, metronoma chemotherapy, colon cancer, and you should get right to that paper. When I was first diagnosed, there was for almost nothing available in terms of advocacy. If somebody had some questions, there was almost no way to get it. Then I discovered some website where there was a discussion group underway. It had some, I don't know, as I recall, maybe 30, 40, 50 patients from various places who were just open and willing to listen to any question and provide an answer. And it didn't take long for me to find out that collectively there was a lot of knowledge here. Some of those patients were just rookies and didn't have a clue, and others were PhDs in biology, and some of them have had various therapies. They knew what the toxicities were. They knew how to deal with toxicities. They knew what the emotional problems were facing a cancer patient, and they had all kinds of support. And this was a group where you could say anything. Cancer patients are less open to discuss certain things with people who are not cancer patients. It just, after you deal with a life-threatening disease, you just change a little bit. But in this group, in this community, you could say anything you wanted. There was nothing out of bounds, and you could get comments. Well, a couple things. First of all, colon cancer is probably the best cancer that responds to early detection. One of our board members has Lynch syndrome, which is a syndrome where he gets many polyps. And I think his father had colon cancer and his grandmother had colon cancer. And this board member has young children, and he gets colonoscopy every 12 to 14 months. So colon cancer is one of the very few cancers where you can actually say with very aggressive screening, you can actually prevent colon cancer. Can't say that about breast cancer, can't say that about prostate cancer or any other cancers, because the colonoscopy can find any polyp and remove it, and that's the end of the story. It's got to be done by a competent GI doc, and it's got to be done right. But if done properly, early detection is really effective in colon cancer. That's the main thing. There are now far more options for someone diagnosed with late-stage colon cancer that were not available when I was diagnosed in 1994. Radiofrequency ablation for tumors that are untreatable by therapy, by chemotherapy. There are more chemotherapy drugs out there. There are a lot more options. Anti-angiogenic therapy. It's better, and it's even going to get better. However, I would say that the best thing you can do if you're worried about colon cancer is have a screening plan. Everyone should have a screening plan, and it's the best option.